Hello everyone. So today we'll be discussing voice and speech disorders. Now voice and speech disorders are actually quite an abstract topic. It is quite vast and different books classify disorders differently. There's a lot of overlap between conditions. So I tried to simplify things and I picked out some of the most important voice and speech disorders and we'll try and discuss them today. As usual, we'll start with the case study. So you have a 12-year-old girl who presented to the ENT OPD with complaints of hoarseness of voice for the past 6 weeks following an upper respiratory tract infection. And she complains of pain in the neck and voice fatigue when continuously using her voice. So you would first think of a structural lesion. Suddenly she develops hoarseness. So you probably think of a vocal polyp or something like that. But what happens? You do a flexible video laryngoscopy and it was noted that there was no structural lesions. And so the vocal folds look absolutely normal. So then why is she having this hoarseness? Okay, so the cords were equally mobile. Okay, and however, when you further look at the video of the laryngoscopy, the phonation of the ventricular, on phonation, the ventricular bands would approximate first, overriding the true cords. And this is a diagnosis of a type of muscle tension dysphonia. And it's called dysphonia plica ventricularis. And the treatment was very, she underwent a few weeks of voice therapy and this type of behavior or this type of compensatory mechanism of muscle tension dysphonia was resolved. So this is the kind of cases that will come and unless you know about these conditions, you will miss it because the vocal folds look absolutely normal. It is the movement that is a problem. Okay, so before we go into these disorders, just familiarize yourself with certain terms. Okay, so what is dysphonia? Any impairment of the voice or difficulty in speaking. It's a broad term. Any impairment in the voice or difficulty of speaking is dysphonia. So what is dysarthria then? So this is specifically when there is difficulty in articulating words caused by the impairment of muscles used in speech. So it's not the production of the sound that is the problem, it is the articulating of that sound or articulating of words that is the problem. So that is dysarthria. So dysarthrophonia, when there is both, when there is a difficulty in production of the voice as well as articulation, and this usually occurs after a cerebrovascular accident, head injury and all. So you have both dysarthria and dysphonia. So that is dysarthrophonia. So what is dysphasia? Dysphasia, there is an impairment in the comprehension of spoken or written language or impairment of the expression of speech or writing. Okay, so there is a language problem. Okay, so there is difficulty in understanding, comprehension or expression. So there is a sensory dysphasia or a motor dysphasia, expressive dysphasia, and it's also associated with brain injury. Okay, and you have hoarseness, which is a perceived rough, harsh and breathy quality of the voice. Okay, that is the definition of hoarseness, a rough, harsh, breathy quality. And odynophonia is pain when talking. So just remember these terms. Now, types of voice disorders. Okay, so you can have an organic disorder. An organic disorder is something where there is actually something wrong with the functioning of the larynx. Okay, so it can be a structural organic condition. That means the conditions that we talked about in our benign lesions, in malignant lesions. So there is something structurally wrong. There is some mucosal lesion. You can see that. Okay, so those are the structural abnormalities. The other is the neurological. So the structure is normal, but the nerves supplying the muscles of the larynx are not working. For example, a vocal cord paralysis. So in those cases, you have a neurological condition or there is some spasm. So these two are the structural and neurological lesions, and these are known as organic lesions. So there is something wrong. In functional, what happens is that the physical structure is absolutely normal, okay, and there is nothing wrong with the nerve supplying also. It's just that the use of that normal structure is being altered, okay, so it's not being used in an efficient manner. So for example, like in our case study, instead of using her normal vocal cords, she started using her false vocal cords, okay, and this probably came back after upper respiratory tract infection when she had a cold. She had some vocal cord edema. That is an organic problem. But that subsided. But then she developed this habit of speaking with her vocal false cord. So that is an inefficient way of using your vocal cord. So that is a functional problem. There is nothing organically wrong with that. So you have organic disorders, you have functional disorders, and then you have a very similar psychogenic disorder. So a psychogenic disorder or voice problem is one which starts as a symbolic or outward manifestation of some unresolved psychological conflict. Okay. So now, like I said earlier, you cannot delineate a particular patient's problem as only functional, only psychogenic, only organic. It may be overlapping. The patient may have an organic problem. On top of that, he may have a functional problem, and on top of that, he may have a psychogenic problem. So a patient's diagnosis may be all three. Okay, so but generally for understanding, you can divide it as organic, functional, and psychogenic. So now we'll the organic structural lesions we talked about in our benign and malignant lesions. So we'll just talk a little bit about the neurological diseases of the larynx. So neurological diseases can be further divided into hyperfunctional and hypofunctional. Okay, and in hyperfunctional, today we'll be talking about laryngeal dystonia and stuttering. There are a lot of others like in essential tremor, myoclonus, pseudobulbar palsy, and all that. In hypofunctional, you have central and peripheral causes for vocal cord paralysis and all the other diseases which causes hyperfunctioning, generalized hyperfunctioning of the nervous system. So you can read up on these. Okay. So let's see, what is dystonia or laryngeal dystonia? So what is dystonia and such? Dystonia is a syndrome dominated by sustained contractions of the skeletal muscles that frequently cause twisting and repetitive movements or abnormal postures that may be sustained or intermittent. So basically you have sustained contractions of the entire part of the body. So either it can be entire, the trunk, or the entire body. So that is a generalized dystonia, or it can involve just a particular muscle, that is a focal dystonia, or it can be segmental where two or more contiguous regions are involved. So you can have different kinds of dystonia. So laryngeal dystonia is a type of focal dystonia. Okay, so the laryngeal muscles alone undergo spasm and they repeatedly contract, and they have and this results in problems in phonation, or results in a particular kind of speech. Okay, so that is known as spasmodic dysphonia. That is a laryngeal dystonia. So spasmodic dysphonia can be adductor spasmodic dysphonia and abductor, abductor. So that means it can affect the muscles that are contracting, closing the vocal cords, that is adductor dysphonia, or it can affect the muscles that are opening. So the only opener of the vocal cord is what? The posterior cricoarytenoid, the abductor. So if it involves the posterior cricoarytenoid muscle, it is known as abductor spasmodic dysphonia. If it involves the closures, that the lateral cricoarytenoid or the thyroarytenoid muscle, then it is adductor spasmodic dysphonia. So in adductor spasmodic dysphonia, okay, in adductor spasmodic dysphonia, the laryngeal muscle suddenly close the glottis, the glottic space close. When the patient speaks, the larynx go into spasm, and because of this, the patient has a very choky, very strained, strangled sound. Okay, and the larynx is morphologically normal, and the treatment involves relaxing the muscles that are causing this adduction. So what are the muscles that cause adduction? Or tensing the vocal folds. So the thyroarytenoid muscle is injected with botulinum toxin. So it's not like a single injection. Repeated injections will slowly cause this muscle to relax, and it will relieve this spasm, and the patient's, and along with that, voice therapy is given, and the patient's voice comes back to normal. In severe cases of spasm, there has been section of recurrent laryngeal nerve to paralyze the cord, but that is only in severe cases. So this is how you treat adductor spasmodic dysphonia. Okay. Now in abductor spasmodic dysphonia, okay, AB, abductor, okay. So here what happens, the posterior cricoarytenoid muscle are going into spasm. So as the patient is speaking, suddenly the vocal cord opens. So what happens? In adductor, the patient had a very choky, very strangled voice. Here he has a breathy voice. As the patient speaks, suddenly it becomes like that. So it has a breathy voice. So this is due to spasms of the posterior cricoarytenoid muscle and keeps the glottis open suddenly. So it has a breathy voice and breathy breaks in voice. And again, larynx is morphologically normal. And here what you do, you inject the botulinum toxin into the posterior cricoarytenoid muscle and you give voice therapy. And in severe cases, you have to treat with thyroplasty, type 1 thyroplasty or fat injection, where the cord is medialized. It prevents the cord from going too much into abduction. So you do that surgery. But that is in very severe cases. So identifying, and sometimes it can be mixed. You can have an abductor as well as an adductor. And identifying whether it's adductor and abductor, you ask the patient to say certain phrases, or you ask the patient to count. Like for example, if you ask the patient to count from 80 to 89, when you say vowels, it goes like A, E, I. So you're keeping the cord open. So if you have an adductor spasm, it will be known. So if you want to diagnose adductor spasmodic dysphonia, you ask the patient to count from 80 to 89. The opposite happens in abductor. If you want to know abductor, you use consonants like 60, 61, 60. So when the patient starts counting from 60 to 69, suddenly the posterior cricoarytenoid will work and patient will have difficulty in saying. And it's just not only counting, there are certain phrases which can identify these conditions, okay, whether it's abductor or adductor. So analysis of the voice will tell you whether it is abductor or adductor spasmodic dysphonia, and accordingly you can inject the botulinum into whichever muscle is affecting. So that was about laryngeal dystonia. So that was one of the hyperfunctional neurological conditions. This is still, we're talking about organic lesions. Okay, this is an organic pathology. So stuttering is also considered a movement disorder. Okay, because it involves abnormal, involuntary and inappropriate use of muscles of speech production that results in a non-fluent or disfluency. Okay, so there is abnormal, involuntary and inappropriate muscle contraction. And this occurs not only just in your articulating. When we think of stuttering, we only think of that initial when the patient starts articulating. So it's not only the articulatory muscles, it's also the respiratory, the phonatory. So the production of sound starts from the expiration. So the respiratory muscles may go into spasm, the phonatory muscles may go into spasm, and the articulatory muscles. And there's increased muscle tension in these subsystems. Okay, it may not be only limited to these muscle systems, other craniofacial muscles. So if you've seen some individuals who stutter, sometimes when they start stuttering, their face goes into a sort of spasm or their eyes starts contracting. So the other craniofacial muscles also go into this kind of sustained, involuntary, inappropriate contraction. Okay, so that may come with stuttering. Now, some competing stimuli, if you divert the patient's attention, okay, like sensory stimuli or some motor actions, like you ask the patient to take a walk or relax, or use of a metronome, like rhythmic patterns, you break that involuntary contraction, that increases the fluency of the patient. Okay, so some competing stimuli will break that sustained spasm. On the other hand, if you put communicative pressures on the patient, like for example, if the audience size is large, if a patient starts stuttering and you urge the patient to express himself more quickly, so in those cases the patient will stutter worse. Okay, so in anxiety, time pressure, social approval, all this communicative pressures put on the patient will make the stuttering more. Okay, so competing stimuli such as sensory stimuli or motor actions like walking, etc., will reduce the stuttering, whereas communicative pressures like audience size, listener reactions, time pressure, all that will worsen the stuttering. So how do you manage this condition? Most of the individuals with stuttering will do well with speech therapy, traditional speech therapy and training. In resistant cases, you may have to do chemodenervation, like you inject botulinum in the thyroidnoid muscles just to relax the muscle and relieve the spasm. Now there are in-the-ear devices. Okay, so in these in-the-ear devices, what it does is it alters the feedback, the auditory feedback of the patient's own voice, and that helps in reducing the stuttering. So you have in-the-ear devices, okay, which provide an altered auditory feedback of their own voice, and that sort of reduces the stuttering. So those were the two hyperfunctional disorders. Hyperfunctional is vocal cord paralysis. Okay, so we'll not go into that, and many other neurological conditions associated with hyperfunctional disorders. So now we'll come to the next. Now we've done with organic lesions. So now we'll come to the functional disorders. Now what are functional disorders? Functional disorders, like I said, there is an inappropriate or inefficient use of normal musculature, normal innervation. There is no spasm or anything here. There is no abnormal contraction. There is nothing wrong with the neurology or structurally wrong with the larynx. Here only the use of these normal muscles is in an inappropriate way. And there is a general term that is muscle tension dysphonia. Okay. So muscle tension dysphonia can be a primary muscle tension dysphonia or a secondary. So primary is when there is no other lesion. Okay, it's just de novo, the patient starts developing this way of speaking for no rhyme or reason. And secondary is when they have a mucosal lesion, which can be temporary or it can be, like for example in our case study, the child had an upper respiratory tract infection. She probably had an organic structural problem like a laryngitis, and it is after that secondarily she develops this muscle tension dysphonia, or probably a patient with a polyp or a Rinke's edema. Chronic Rinke's edema, patient not able to speak well, he starts using his Hall's cord. So it can be secondary to some organic pathology. Okay. So there are many different kinds of, there are different grades, grade 1, grade 2, grade 3. So one of the grades is ventricular phonation, that is dysphonia plica ventricular. So today we'll be discussing only on that. So what is ventricular phonation? So the voice is produced by the ventricular folds which have overtaken the function of the true cords. So when the vocal cord starts approximating, the false cords come first and they adduct, and the voice is produced by the false cord. And the diagnosis can be made by an indirect laryngoscopy if you observe the movement, and it can be helped through voice therapy and psychological counseling. Okay. So that is about muscle tension dysphonia and the functional disorders. Now we come to the psychogenic voice disorders. Okay. Now this classification may be overlapping. You know, some of the books may give these psychogenic voice disorders as a functional disorder. Okay. So here also there is nothing wrong with the vocal folds, but there is a psychological aspect to it. So it is some hidden psychological problem which is manifested as a vocal cord problem. Okay. So one of the conditions is conversion dysphonia or aphonia. Okay. And the patient suddenly, usually a young female, suddenly she does not have any voice. So when you look at the vocal cord, it's abducting and adducting well. Patient, when you ask them to cough, is able to cough out. Only thing, when you ask the patient to speak, they're not able to speak. They're not able to phonate. Okay. So that is conversion aphonia. Okay. Or functional aphonia. Another kind of disorder is Februophonia or mutational falsetto. Okay. So this is important. So normally when children, the boys especially, when they mature, when they are around 14 years of age, when they hit puberty, their voice drops, their frequency of the voice drops, and they develop that male voice. Okay. And they lose that childhood high-pitched voice. So in some individuals, this does not happen. They tend to, although their larynx are normal, they develop all the secondary sexual characteristics as normal. They're normal in all other ways. Only thing is that they continue to use that high-pitched voice. They do not develop that voice maturation, and this is known as, the failure of this change leads to persistence of childhood high-pitched voice, and that is known as Februophonia. And it is usually seen in children or boys who are overly emotionally attached to their mothers. They feel insecure, they fail to take up responsibilities. So those are the psychological aspects which manifests as a voice disorder, that is Februophonia. So the treatment is obviously to address the psychological problems and also to train the body to produce a low-pitched voice. So the vocal cords are unduly stretched, and they use that stretched vocal cord to speak. So what do? You just press the thyroid cartilage. So when you press the thyroid cartilage, the vocal cord relaxes. So you train the patient to speak by pressing on the thyroid. So this is known as the Gutzmann's pressure test. And obviously you give voice therapy and all, and you ask them to train themselves to speak in this low-pitched voice, and slowly they overcome. And obviously you address the psychological problem also, and then they recover. So with that we come to the end of the functional psychogenic voice disorder. So I just touched upon the important neurological disorders, functional disorders, and the psychogenic disorders. And two other things that you need to know are hyponesality, okay, and hypernasality. Okay, so voice is produced from our vocal cords. Okay, so that is phonation, and this sound is now resonated and articulated in our resonating chambers in the pharynx, nasopharynx, sinuses. So all these upper respiratory tract structures play a role in the final sound that we produce. Now what happens if something goes wrong with that resonating chain? Now one of the main problems is hyponesality or rhinolalia clausa. So when you think of clausa, you think of closed. So your nasopharynx is closed. So whatever air in certain sounds, you need air coming out through the nose as well to produce that kind of sound. So there in clausa, that is closed. Your nasopharynx, the communication with your nose and nasopharynx is closed. Rhinolalia clausa, and that is known as hyponasality. Okay, so that occurs. Now think of all the conditions that can cause a nasal obstruction or a nasopharyngeal obstruction. So obviously it is common cold, allergies, nasal polyps, nasal growth, adenoids, nasopharyngeal mass. Okay, and obviously habitual. So just think of everything obstructing the nasopharynx and nose. Okay, so you will know what is closed. Rhinolalia clausa. The opposite is open, aperta, okay, or hypernasality. That means there is more air going into the nose. Okay, so when does that happen? When there is a velopharyngeal insufficiency, there is a congenitally short soft palate, submucous cleft, large nasopharynx, okay, and cleft and soft palate, paralysis of the soft palate, oronasal fistula, and habitual. So think of all the areas which can open a communication between the oropharynx and nasopharynx. Okay. So now if I close my mouth, see, this is how my voice will sound like. So this is rhinolalia clausa because I've caused an obstruction. Okay. So that's an example of rhinolalia clausa. And so remember the conditions for rhinolalia aperta and rhinolalia clausa. Okay. So with that, we come to the end of our discussion. Let's take up a few questions. Okay. So types of spasmodic dysphonia. You can have abductor, AB, abductor dysphonia. And to diagnose abductor dysphonia, what do you do? So what happens in abductor dysphonia? Suddenly, as the patient speaks, the vocal cords abduct. Okay. So when they abduct, they have a breathy voice. Okay. So you ask the patient to say consonants like, or certain phrases like you count from 60, 60, 61, 62, 60. When they keep saying that, suddenly the vocal cords opens and the 60 becomes so it becomes breathy. Opposite happens in adductor. You tell them, you ask them to say phrases which inherently keep the vocal cords open, like you say vowels, I, ow. So my vocal cords are actually open. So you say, tell them to say 80, 81, 82, so A, and suddenly there is a spasm of the adductor. So the A becomes A, so it becomes strained. So that is adductor. And sometimes you can have a mixed variety. Okay. So you have an abductor spasmodic dysphonia, adductor spasmodic, and these are all examples of a laryngeal dystonia. So this is a laryngeal. So the answer is all of the above. So stuttering is best managed by, no, there is no surgery. Antidepressants don't work very well. The only thing is speech therapy that is required. If there's any psychological overlap, you also address that, but you mainly give them speech therapy. You ask them to train themselves to speak and they will respond. Okay, you divert. You remember that competing stimuli, you give competing stimuli so that when they start stuttering, you divert their attention and you reduce the communicative pressures so that the stuttering doesn't worsen. Februophonia. Is it a psychogenic voice disorder? Like I said, the classification varies, but yeah, in this thing we include it as a psychogenic. Some books take it as a functional disorder as well. Seen exclusively in males, yes. Seen in boys who are insecure, emotionally attached to their moms, yes. So all of the above. Okay, so febrophonia. Rhinolalia clausa, closed. Clausa, my nose is closed. So what happens to my voice? This is rhinolalia clausa. So think of all the causes. Common cold, yes, causes nose block. Submucosal cleft palate. So there's an opening between your mouth and nose. So that's quite the opposite of clausa. So that is aperta. Okay. So in cleft palate you get aperta, rhinolalia aperta. In adenoids, yes, again it's closed. So, nasal polyp, again it's closed. So rhinolalia clausa or closed is in all except, this is your answer, submucosal cleft palate, which is seen in aperta. The mainstay in the treatment of laryngeal dystonia. So laryngeal dystonia is what? It is a focal dystonia. It's also known as spasmodic dysphonia. Two types, abductor and adductor. So in spasmodic dysphonia, what is the mainstay of treatment? Will speech therapy help? It is a movement disorder. There is something wrong. So speech therapy alone won't help. You will have to relieve that contraction, those spasms And how do you relieve the spasms? You give botulinum injection. You inject whichever muscle group is going into dystonia. So if it is the abductors, that is the posterior cricoarytenoid, you give injection to that. If it is the adductors, usually the thyroarytenoid that is going into, then you give in the thyroarytenoid if it's adductor spasmodic. So botulinum injection is the treatment of choice. So with that, we've briefly covered all the voice and speech disorders. Thank you.
Docemy.